Hi everybody, thanks for coming today. We're really pleased to have Professor Andrew Rundle from Columbia University in the US. Andrew's a professor of epidemiology at the Mailman School of Public Health, and his research is preliminarily focused on the determinants of sedentary lifestyles, obesity, and the health-related consequence of these conditions. And I've known Andrew for, we were saying about, I think I went to visit Columbia University about 9 years ago, and Paul went, I think 11 or 10 years ago. We couldn't quite work it out. And we've worked together, and Andrew does some really cool stuff using Google data and his team, and we've linked that to some of our data sets here and done some quite interesting studies. I'm really pleased that Andrew's going to talk about how he's linked some data around the built environment to health outcomes. So I'll pass over to Andrew.
Thank you very much. Thank you for having me. Thank you for coming out. It's a pleasure to be here to speak with you. As I was putting this together, I realized this is going to be a very United States-centric talk. In fact, a very New York City-centric talk. So hopefully not too boring. I'll try and make it relevant. So I'm going to be talking to you about some of the work we've been doing for at least a decade, studying urban design and the extent to which urban design allows people to engage in physical activity, and then sort of the consequences of being physically active, having a healthy weight for cancer outcomes. So I'm going to be talking a lot about obesity and overweight, so I thought I would just define them up front. So overweight and obesity are defined as an abnormal or excess accumulation of fat that prevents a risk to health. And body mass index is one of the most common ways of sort of defining normal weight, overweight, and obese categories. And I put the formulas for BMI in US and metric up here for you. So underweight is a BMI below 18.5, normal 18.5 to 24.9, overweight 25 to 29.9, obese greater than or equal to 30. Let's do a little demonstration. So I'm 209 pounds, I'm 73 inches tall, gives me a BMI of 27.6. I am really solidly in the overweight category. There's a lot of discussion about whether BMI is a useful statistic, right? Like a lot of people criticize BMI. It doesn't differentiate between fat tissue and muscle tissue, bone tissue, lean mass, fat mass. And I actually like the BMI statistic a lot. And I would say in America that we do not have an epidemic of fitness. We do not have an epidemic of buffness. That's not a thing that is happening in America. We have an epidemic of adiposity, right? And so there's very little confusion that happens in the BMI statistic on a population basis, because we just don't have a lot of super athletic people walking around part of society in the US. I got a big grant from the NIH to put 300 people through an MRI machine to measure all the different components of fat, subcutaneous, and so on, and divide up their fat tissue into different depots. And I learned nothing from that I didn't already know for BMI. So it turned out that just knowing height and weight for predicting the health outcomes of these individuals was just as useful as cutting-edge MRI data. And I stuck a bunch of people and spent a lot of money on MRI machines, and it turned out that I didn't really learn anything extra. So I feel like it works really well for the kind of epidemiology that I do. Probably not so well for like purely clinical things, but for like population health statistics, it works well. So obesity is linked to cancer risk. So NCI and IARC have said that obesity is associated with increased risk of 13 different kinds of cancer. We got this little atlas of the human body over here, sort of pointing out the various cancers that have been linked to obesity. Analyses in the US suggest that among those aged 30 or older, 37,500 new cancers per year in men and 74,000 in women are due to overweight or obesity. And so there's a strong link between obesity and certain cancers. And then some fairly old statistics. A paper came out in 2019 that looked back at 2012 and suggested about 4% of all cancers could be accounted for by excess body weight. Physical activity is also associated with the lower risk of 7 cancers. But the interesting thing is that for most of those cancers, it doesn't seem to be because physical activity is associated with lower body. It seems that physical activity has its own biochemical, biological processes that protect against cancer, independent of a route through excess body fat or maintaining a healthy body size or fat level. And so a lot of my work is focused on this sort of link between obesity and cancer, and whether we can see there are factors that protect against weight gain that we can then link further out to obesity risk and cancer risk and cancer outcomes. So what is the state of obesity in America? So this is one of the CDC's obesity maps. So this is based on a telephone survey. So you have to imagine I'm sitting home, my cell phone rings, CDC here, we'd like to ask you some health questions. Would you be willing to take our survey? Sure, why not? A whole bunch of questions get asked, and then they ask me, how tall am I? And I'm like, I'm definitely 6'2". How much do you weigh? Definitely 195 for sure. And it's pretty standard that people overestimate or lie about how tall they are, underestimate or lie about how much they weigh. And so if you overestimate height, underestimate weight, you underestimate BMI. So I think these maps are kind of like the best case scenario, because they're based on self-report telephone surveys, and we know which way sort of the information bias goes in these surveys, right? So I think this is best case scenario. So this is 2011. And so green is 20 to 25% prevalence of obesity. Yellow is 25 to 30. Sort of the orangey pink, 30 to 35. Keep your eye on Colorado, which is the square state in the middle. And we can flip through time. So we get more yellow. 2013, we get our first darker red with states now above 35%. Colorado is still green. Additional states turning red in 2014. More states turning the pink and the red color. All of the states are now yellow or worse, except for Colorado and Massachusetts and Washington, D.C. and Hawaii. Keeps going. Mississippi now has turned dark red, so above 40% prevalence of obesity. Colorado is still hanging on green, as is Washington, D.C. Mississippi flips back. Now we're basically all red. 2022, the entire country goes red except for a few places. Colorado is still hanging on as one of the lower prevalence states. I really think that the difference from 2021 to here, I think that's COVID weight gain. I think there's a lot of at-home work, overeating, video game playing for 2 years. And I think it starts to show up in 2022, but there's this sudden jump from 21 to 22 in the obesity prevalence. And so this is the state of the most recent CDC data for the nation. As I said, I think this is an underestimate or best case scenario of what the US looks like for the prevalence of obesity. There's also some stark disparities in the prevalence or risk of obesity. And so what I've done here is, this is New York City data. The most recent data for New York City is 2018. There's this huge gap in the data for New York City because of the COVID. Everybody in the entire Department of Health shifted its focus to COVID. And so we don't have any more recent data, really. And so what I've plotted here is the prevalence of obesity by sex and race ethnicity. And so you can see amongst Black and Hispanic residents in New York City, this big disparity in the prevalence of obesity by sex. You also see that Black and Hispanics have the highest prevalence of obesity in the city. Asian and Pacific Islanders the lowest. This is household income by sex, going from the lowest income on the left to the highest income on the right. The blue bars are men, and you don't really see any trend in the percent or prevalence of obesity by income amongst men. You can be obese or overweight and wealthy, and there is no social stigma associated with that. But amongst women, there is this downward trend, right? And so you see the prevalence of obesity is highest in the lower income bracket and is lowest in the highest income bracket. And you can basically make this plot for data from most places in the United States. And so there's two theories on the sort of disparity amongst women by income. One is that there is social stigma for heavier weight, and wealthier women can convert income into activities like physical activity, healthy diet that are associated with lower weight. The opposite theory is that because of the social stigma, particularly directed at heavier women, there is a pay penalty, there is a hiring penalty, there is a promotion penalty. And it turns out, as best we can tell, that both things are true. And so there's both a sort of like utilization of higher income to achieve this sort of social norm. And then there is this stigmatization that produces disparities in income that also sort of magnifies this graph. Whereas for men, there's far less stigma, and we don't see this sort of like trend that we see here. But we have this sort of underlying, and I've done this for like the 2000 data, the 2005 data, like you can just keep doing this over and over again. It just replicates through all the data sets. So we have these underlying sort of social disparities to understand before we even start talking about neighborhoods. Looking at physical activity, only 23 of US adults meet the physical activity recommendations. This is the graph going back to 1997. We've made such limited progress in sort of getting people to achieve the physical activity recommendations in the United States. We sort of peaked in 2017, almost got 25% of the adult population engaging in physical activity that is enough to promote health. This is the physical activity map. CDC relatively recently started publishing physical activity maps. The darkest color is 28.5% prevalence of meeting health recommended physical activity. You can take this map and lay it over the top of some of the obesity maps, and you can sort of see this really nice spatial correlation between the maps for obesity and the maps for physical activity. As you would guess, the places with the lowest physical activity have the highest prevalence of obesity in these maps. And so the United States is experiencing this epidemic of obesity, this epidemic of sedentary lifestyles, and has been for decades. The CDC sort of discontinued their maps and their methods, so you can actually go all the way back to 1990, but there's this glitch that happens in around 2011 where they change their methods. So I only show the 2011. Like, you can do this now over 20 years or more of data. So one thing we observed is that obesity has increased more rapidly amongst cancer survivors compared to the general population. So I've got a couple of graphs here. Start with one. This is individuals with no history of cancer is the bottom line. And then we have, for women, breast cancer, all cancer, and colorectal cancer. And you can see that the curves are steeper for the populations that are cancer survivors. So the prevalence of obesity is rising faster amongst cancer survivor populations versus individuals with no history of cancer. Likewise for the men, particularly for colorectal cancer. So we have this gain in weight that we're seeing in these populations. We break this down by race ethnicity. What you see is the blue lines are women. The solid line is with a history of cancer. The dotted line is without a history of cancer. So amongst Hispanic women, the lines are more or less parallel. Amongst men, you see the splitting of the lines. Amongst non-Hispanic Blacks, you actually see the biggest gains in obesity prevalence amongst cancer survivors versus those without a history of cancer. And you see the dotted and the non-dotted lines diverging substantially through time. Non-Hispanic whites, you actually see that the lines sort of are basically parallel, sort of fall on top of each other. And so the story of weight gain is actually very much a story of race ethnicity as well as cancer survivor versus people without a history of cancer. So again, we see these disparities, these social disparities in weight gain and obesity in the United States. So it turns out that obesity and gaining weight during survivorship is not great for outcomes. So obesity seems to worsen several aspects of cancer survivorship. So reduced quality of life, higher reoccurrence and cancer progression for some cancers, worse survival, higher risk of certain second primary cancers. And amongst breast, colorectal, prostate cancer survivors, physical activity after diagnosis is associated with lower cancer-specific mortality. So we see post-diagnosis that physical activity, adiposity are important factors of the survivorship story. So we have an impact of obesity both on incidence and then the lived experience of cancer survivorship, chances of progression, and outcomes of progression and death. So I want to tie this now back to one of the things I spend a lot of my time talking about is this idea of how neighborhood-built social environments might impact obesity. And this is obviously actually a super simple idea. Basically, the built and social environment in our neighborhoods provide a context in which we engage in physical activity and nutritional behaviors. And these environments can be supportive, inhibitive, or neutral towards physical activity and healthy diets. And we argue that variation in neighborhood built and social environment characteristics influence physical activity, diet, and in turn body size of the residents, the communities, the populations that live in neighborhoods with different physical environments and different social environments. I don't think that's a radical idea anymore. When we first started talking about this back in like 2002, and I told my advisor this is what I wanted to do, he thought that was like a really radical idea, but I think it's become like quite normalized now. So I spent a lot of time working on this concept of neighborhood walkability, and this concept has come out of the urban design literature and sort of been transported over to public health. So urban designers in the US talk about the D variables: density, diversity, and design. And some of these D variables are residential density, intersectional density, land use mix, subway stop density, or transit density. And they have this really weird variable that they talk about that's hard to explain called retail building floor area to retail land use ratio, which is basically a type of commercial space where you can step off the sidewalk into the commercial space, versus you have to walk through a parking lot or a strip mall to get into that retail space. And so you imagine like a high street in England or Broadway in New York, it's the kind of retail where you can just step into the store, and that is believed to be good for physical activity. Whereas a kind of retail or commercial space where you have to like drive, park your car, walk through the parking lot to get to the store is thought to be bad. And so I've grabbed two screenshots that demonstrate high walkability and low walkability in New York City. And so the top one is the Upper West Side. No, it's not. It's actually in the Village. This is a typical high walkability scene in New York City. And so the first thing you see, there's a ton of pedestrians. Okay, that's a good sign for walkability. There's mixed land use, so you have a combination of retail, residential, commercial. You've got a gridded street structure. You can get to places easy, like you're not stuck in cul-de-sacs. Meanwhile, this is an image from Queens, which is one of the boroughs in New York City. So what you see here are single-family homes, driveways, cars in every driveway, literally no sidewalks, right? Like there is no place to walk except for the street. And so this is out in Queens, which is a very low walkable area in New York City. You can also distinguish high and low walkability just using Google Maps, right? So I've grabbed two Google Maps shots. One is in Manhattan and the other is in Queens. And so the way you can think about the walkability is in the high walkability area, you have gridded streets, so it's very easy to move through space. You've got lots of transit, you've got dense buildings, dense retail, dense residential areas. The low walkability area has got this like weird street layout where you can't get towards sort of like this area. Each of these little squares is a building, it's a single family home. It's not easy to get to point A to point B because it has these like loops. There's literally only one business in this neighborhood. It's Amy's Balloon Store. Now, if you lived in this neighborhood and you had a need for balloons, you were all set, right? Like you were hooked up. If you needed a quart of milk, gallon of milk, whatever unit of milk they sell here, if you needed milk, you're going to get in your car, you're going to drive to the supermarket, you're going to park your car, you're going to walk into the store to buy your milk and then reverse it, right? In Manhattan, if I need a quart of milk, I get off my couch, I go downstairs, I walk down the street, I buy the milk, I turn around, I walk home, right? Just these little tiny expenditures of energy, these little tiny blips of physical activity, just doing the things I need to do day to day. So we spent a lot of time developing indexes or scales so we could measure walkability and take these urban design metrics, convert them into like numbers that we can then label different areas of the city. And so this is one of our earlier efforts with a walkability index that is based on some of Lawrence Frank's work. So the red areas are high walkability, the pink areas are low walkability. These are, I think these are 100-meter grid cells, so we can like measure walkability in New York City down to very high resolution, really small spaces. And so we've been spending a lot of time developing walkability metrics that try and build on urban design theory and turn that into quantitative numbers that we can then assign to neighborhoods or areas or census tracts. So one of our earlier pieces of work is we partnered with the New York City Department of Health, which we do a lot of partnerships with. And they have a telephone survey they do every year of roughly 10,000 people. And they ask them, what's your height and weight in the survey? And so what the CDC does for the nation, New York City Department of Health does for the city. So we pooled 4 years worth of data, and we had the zip code that people lived in. And zip codes in New York City are very small. Like out in Wyoming, they're huge, but in New York City, they're very small little spaces. And this is a graph of our results where I'm plotting the difference in BMI across the interquartile range of 5 neighborhood descriptors that we built. And the red dots are the point estimates, confidence intervals. The red dotted line is the null. So what we were able to show is after adjusting for a bunch of individual level factors and mutually adjusting for the variables in the graph, that the percent of the neighborhood that was a large park and the percent of the neighborhood that was a small park was associated significantly with lower BMI. Higher neighborhood walkability was associated with lower BMI. We were able to get data on like how much garbage was in the park, graffiti, whether the park was broken down or not, and we created sort of a park disorder metric. So the more disordered or sort of lower quality the park was, the higher the BMI, and we use homicide rate as sort of a marker of crime and violence. And so you see that areas with more disorder, more crime associated with higher BMI. But what you see is that neighborhood walkability is the strongest predictor of BMI in this data set. We all think about going to the parks to work out, ride bicycles, run, whatever. Turns out the neighborhood walkability variation in that is a stronger predictor of BMI than access to green space or park space in New York City. And we have a lot of park space in New York City, but it turns out walkability is a stronger predictor. In another project, we partnered with the DOH. They recruited about 700 people, but we actually only got good data on 509 people. These individuals wore a GPS tracker and an accelerometer to measure their location and to measure their physical activity. On the panel on the left, you can see the GPS data in red. The data are so dense that you can basically plot out the street network of New York City just from the GPS data. And so you're looking at Lower Manhattan and Brooklyn, so you can see the bridges going over the river. This kind of like swirl over here. That's the Staten Island Ferry. Those are people commuting to and from work on the Staten Island Ferry. So what we did was, it's fairly typical to sort of define a neighborhood as a 1 kilometer space around the home. This is sort of a metric that's been used over and over again. So we took 1 kilometer circles around the home of each of these individuals. And then we took their GPS data, which are these dots here, and we built these sort of minimally convex holes around those dots to try and sort of build a metric of how much space they actually used, okay? Now, if you've ever seen one with like a National Geographic or a nature program where they put like a GPS collar on a wolf, and then they map where the wolf goes, and then they say this is the home range of the wolf. So that's the exact same approach we used here. So these are like the wolves of New York and how much space they use. And it turns out that your typical New Yorker uses a lot less space than that like 1 kilometer circle around their home. New Yorkers actually have this kind of much more compact space that they use. So we did this for all 509 people, and we measured walkability in the overall circle and then just in these sort of like holes that we created. And obviously these holes are weird. There's all this white space here that this person never went into, but it gets included in the hole. So this is like not a perfect way of sort of thinking about the home range of a New Yorker, but this is the approach we took. And this was sort of like relatively early days in the GPS data collection world. So one of the things we did was we measured the neighborhood walkability in the area that people actually used versus the area within 1 kilometer of their home that they never used, okay? And what you see here is that the walkability of the area that people use is significantly higher than the walkability of the area that they don't use. So people are preferentially, in our data set, utilizing the space that scores high for walkability, or preferentially not using the space that scores low for walkability. And so we had done a bunch of analyses to show that based on the GPS data, we could show that walkability seemed to correlate with the actual minute-by-minute, second-by-second behavior of where individuals went in their neighborhood. They were also wearing this accelerometer, so we could measure physical activity. And so what I've plotted here is across the x-axis is the quartiles of neighborhood walkability, and then the minutes of moderate equivalent physical activity per week. The red dots are the point estimates, and the brackets, the 95% confidence intervals. These are the model predicted mean estimates. So you can see this sort of like stepwise upslope. As walkability increases, physical activity increases significantly. And the difference between the lowest quartile and the highest quartile is 100 minutes of moderate to vigorous physical activity. So the CDC recommendation is 150 minutes, right? And we're accounting for a difference of 100 minutes just based on differences in walkability in New York City. This is like an insane effect size. Like this is a really huge effect size when you think about the world of physical activity research. And I think part of what it is that if you live in a walkable neighborhood in New York City, you don't own a car. And as soon as you don't own a car, everything you do is about walking, right? Like walking becomes your #1 behavior for sort of transportation. Or you take the bus, you take the subway, but you still got to get there. Right? So my journey to work from my apartment, including the subway ride, is 3,000 steps. I do 6,000 steps just getting to and from work in New York City. So we walk a lot. So what we really wanted to do is we wanted to connect our walkability metrics to these large cohorts that exist, where we've followed tens of thousands of people through time and we've looked at health outcomes. But to do that, we needed some kind of metric that we could systematically replicate year after year, going back decades. And so we put some effort into this. We've come up with a metric where we can measure walkability for the past 3 decades in the US. And so from 1990 onwards, we published work showing that we use population density, intersection density, sort of, destinations of daily living, and rail transit going back 30 years. And so this idea of destinations of daily living. So these are the destinations that you kind of need, like a grocery store, an ATM, a bank, all of these places that you need to go to sort of like fulfill the things you need to do. And so there is this really interesting data set in the US. So there's something called a DUNS number. A DUNS number is like a social security number for an entity that wants insurance, a bank account, to pay taxes. Basically, you need this DUNS number to engage in any kind of economic activity in the US. And it has come to sort of like function like a social security number or a personal identifier. But for establishments or business entities, anything that needs to be engaged in the modern economy in the United States needs a DUNS number, okay? And so there's this enterprising group that had published this data set called the NETS data. The NETS data is a census of DUNS numbers for January of every year. So it's got millions and millions and millions of entries. And it's basically a census of all entities that meet a DUNS number from 1990 to 2000. And the interesting thing is they also have what's called a standardized industry code. This allows you to understand what the business entity is, okay? So we've basically taken this data and the SIC codes, created a giant list of SIC codes that represent banks, grocery stores, all of these businesses that we think are important for daily living, cross-referenced it against the SIC codes and the DUNS numbers. So we have the location of every entity in America, January of every year, that you would probably need in your daily life or weekly life or monthly life. So we can sort of see where everything is that would influence, hopefully, your daily activity. And so this is one of the sort of ideas from urban design, like density of businesses, right? The places you need to get to. So we put together a paper showing that we could go back to 1990 and now measure walkability each year anywhere in America using these data. Now that's my salesman pitch if you want to use my data. It turns out that street maps in the US really are terrible before 2000. Like you cannot measure intersection density in the United States before 2000 because the digital street maps are just so bad. So you really can't do intersection density before 2000. Rail transit, all right, we kind of oversold that. Like if we put a ton of effort into it, we can do it for 1990, but doing it for every year is probably more effort than we could probably really realistically do for the entire United States. But we can do population density and destinations of daily living and create an index out of that that is a measure of walkability that connects back to these urban design ideas. So realistically, if I want to measure anywhere in America every year since 1990, I can do it for these two metrics and create an index. All right, so what am I doing with this data? We partnered with NYU's Women's Health Study team, which is a prospective cohort of 14,000 women that were recruited from 85 to 91. These women came from the tri-state area, which is New York State, Connecticut, New Jersey. A lot of them lived in New York City, but a lot of them also lived out in the suburbs. They've been followed up to January 1st, 2017, mean follow-up of 24 years. At baseline, which we're going to call 1990, we poured a ton of resources into creating our 4-item walkability index so that we could measure walkability where they lived at the beginning of follow-up for 1 kilometer radial buffers around their homes. And then during follow-up, we used census tracts, and we measured walkability using our 2-item index, which is based on population density and destinations. The 2-item metric and the 4-item metric, they're highly correlated at 0.76. So a lot of what gets explained by the 4-item index is really just explained by population density and destinations. So this is back in 1990. What I'm plotting here is the neighborhood walkability index. We call this version 2.0. And the difference in met hours of walking per week. So you can see on this graph on the left that there is this sort of strong association between walkability and engagement in walking amongst the participants in this cohort. Then also in 1990, you can see that there's a strong association between neighborhood walkability and lower BMI at baseline in this cohort. So our walkability index is performing exactly as we would hope. It predicts engaging in walking, but it's lower BMI. This is back in 1990. So now we've followed all of these women up through time. There were 793 deaths in the cohort for obesity-related cancers. So the first thing we looked at was mortality from obesity-related cancers. And so I'm plotting the hazard ratio for mortality from obesity-related cancer against walkability. And you can see there's a significant protective effect of neighborhood walkability on death from obesity-related cancers in this cohort after adjustment for a bunch of variables and many, many, many sensitivity analyses and reanalyses and removal of variables, adding in variables, and so on. It really was a very stable finding. This is total obesity-related cancers. This is incidence of obesity-related cancer. And again, we're looking at neighborhood walkability, but this time it's the average for the entire follow-up period. So for each woman, we calculated through time all of their walkability indexes for every place they lived. We took the annual average walkability index for their entire follow-up period. And you can see for incidence of a total obesity-related cancer, which was 2,411 cases, again, this protective effect of increasing walkability on obesity-related cancer. And so the primary obesity-related cancer is postmenopausal breast cancer, which was 1,269 cases. And so here it's almost like this linear association between quartiles of walkability and the hazard ratio for obesity-related, postmenopausal breast cancer here. And so we're now starting to be able to link walkability back at the baseline of the cohort to BMI, to physical activity, and then the total experience of walkability during follow-up in the cohort to these obesity-related cancers during the course of follow-up, and also mortality from obesity-related cancer, showing walkability has this inverse association with risk for these outcomes. I'm also interested in survivorship. So for many of these cancers, treatment is really good. We're doing a good job treating these cancers. So we have many, many survivors in the US. So now we're looking at urban design and physical activity and body mass index in two cancer survivor cohorts. One of them is in Detroit, which we call the Detroit Rocks cohort. It's 2,000 African-American cancer survivors, first primary breast, prostate, or colorectal cancer. Our initial analysis of BMI, which is at recruitment. And recruitment was more or less 20 months after diagnosis. So there's a pretty good lag period between diagnosis and when these women were enrolled into the cohort. The other cohort is the Women's Circle of Health follow-up study. This is another longitudinal cohort of African-American cancer survivors. This is just breast cancer. They were able to get baseline data more like 10 months after diagnosis, so about half the time we were able to do in Detroit. And we were able to analyze 785 women at their first follow-up. So the first follow-up was about 12 months after baseline. So about 22 months after diagnosis. 58% of the women had experienced weight gain during cancer survivorship in this cohort. So what I'm interested in is how does urban design, social environments, neighborhood environments predict weight gain trajectories in these two cancer cohorts. We're now just about getting to the point where we have enough repeated measures of BMI that I can start to do some kind of like time varying analysis. We haven't cooked those analyses yet, but hopefully soon. So we just have these first analyses of the first measures of BMI. So this is in Detroit Rocks. So I don't know how many of you are familiar with Detroit. It's got kind of like this hollowed out urban core, sort of post-industrial, lots of abandonment. And so our population comes from both that sort of like urban core, but also from the wealthier suburbs. And so there's sort of a range of experiences in this cohort. And they're all sort of being treated at the major cancer centers that are actually physically in the middle of Detroit. And so again, you're probably bored of seeing this slide because it looks like all my other slides. Again, neighborhood walkability is associated with lower BMI during the survivorship period in this group of survivors. And again, we have like quite a nice trend. I've showed you this slide. I've just relabeled it 5 times, but trust me, it's different data each time. And then here, this data is sort of more recent in some ways. So we've only really done the density of walkable destinations as the predictor. And this is the relative risk for weight gain. Okay, so we have 2 time points here. We have 10 months after diagnosis and then 12 months after that, so 22 months. So we're looking at the odds of weight gain here. And what you see is as the density of walkable destinations increases in the neighborhoods where these women live, the odds of weight gain are significantly lower as density goes up. And again, we've adjusted for a bunch of variables, and we've done analyses adjusting for additional variables, more parsimonious models, and we don't get really a lot of fluctuation with different models around this. So what we're seeing is not only does neighborhood walkability seem to be associated with lower risk of obesity-related cancers, it seems to be associated with lower BMI or lower odds of weight gain for survivors as well. And remember, weight gain during survivorship for some cancers, particularly breast cancer, is associated with poor outcomes during survivorship. And so we're hoping this is part of the story of why we see an association between overall mortality for obesity-related cancers and walkability, because not only does walkability sort of prevent the incidence, it makes survivorship better as well. So our conclusions, our work and the work of lots of other people. So this finding of sort of walkability and BMI and physical activity is not unique to New York City. So this is work that has been sort of echoed and replicated in different locations across the US and Europe and Australia, this link between walkability, physical activity, and BMI. We show consistent associations between higher neighborhood walkability and higher levels of physical activity, lower BMI, lower obesity risk, and less weight gain. We've also shown that neighborhood walkability predicts quicker time to glucose control amongst type 2 diabetics. Again, we think through increased physical activity. But this is the first data showing that higher neighborhood walkability is associated with a lower risk for obesity-related cancers and a lower risk of death from obesity-related cancers. We're also showing amongst African-American cancer survivors, higher neighborhood walkability is associated with lower BMI, lower risk for weight gain. And if you remember my slide where I had those graphs of weight gain amongst cancer survivors versus individuals without cancer history, it was in the African-American women that was showing the greatest divergence between those two lines, right? It's African-American women cancer survivors that showed the highest weight gain compared to African-American women without a history of cancer. So I've been arguing that this kind of work by my team and the work of lots of other teams supports the idea of using urban design for walkability as part of a sort of overall public health approach to cancer prevention and control. I also argue that the health benefits for these kinds of urban design projects should be factored into the return on investment calculations that are done when we contemplate infrastructure projects. So we have a subway that sort of goes up here and then dead ends because we can't get it together to build the rest of the subway line all the way up to the top of Manhattan. And in part, we can't get it together because the cost projections are so high to build this subway line. But these return on investment calculations, they often don't include health benefits as part of that sort of cost benefit structure, right? So we've been arguing that if we can start to document health benefits and we can start to put dollars on those health benefits, we can start to rethink some of these stalled out infrastructure projects we have in the US, because I think we're undercounting this return on investment because we're not talking about health many times in these conversations. So what are we doing with this work? Most of my projects involve a collaboration with the Department of Health. So I work very closely with the New York City Department of Health when we're in New York City. And part of my thinking is New York City has got awesome data. And if they're on my team, I have a great way of getting my hands on that data. The other part of my thinking is if the Department of Health is a co-author on my paper, I'm instantly translating data to the #1 health authority in my city that can do something about it, right? There's no like calling a meeting and doing a PowerPoint presentation. Like they're literally writing the results section and the discussion section with me when we write these papers. So as a result, the New York City Commissioner of Health writes these important but boringly titled documents called the NYC DOH MH Data Brief, which is like a policy document supposedly from the desk of the Commissioner of Health that states something that the city should do to improve the health of the population. And so our findings form the basis of one of these sort of policy briefings. New York City published a bunch of documents on rebuilding the city. They published these building guidelines on how we will build buildings, how we will construct neighborhoods. And a lot of that was focused on using urban design to promote physical activity. And so all of our work that we've done in collaboration with New York City is now factored into these guidelines for urban design. And like, people think of New York City as this like fixed thing. The truth of the matter is, like, we are tearing it down and rebuilding it all the time. This is like continuous construction in New York City. But now the guidelines that you have to follow to build stuff starting to factor into health as part of that set of guidelines for what you're going to do. There's also something called the International Wellbeing Institute. This is a for-profit entity that establishes building and design guidelines to cook health into projects. Are you familiar with LEED for environmental sustainability? Okay, some people, yes, maybe. All right. It's just a very American thing. If you're a big American company and you're going to build like your headquarters, you really want this certificate on the wall that says you are LEED Platinum, which means that your building is environmentally sustainable. It's not bleeding heat. It's not bleeding energy. And the idea of the International Wellbeing Institute is that they are going to create a similar plaque that companies are going to compete for that says that their project, their building, is designed to promote health. They also have a community standard. So if you're doing a big redevelopment of a community, they've got guidelines how to rebuild that community to cook health into that design. A competing product is the Fitwell design, which was originally done by CDC. The CDC got this design certification program up and running, offloaded it to the City Center for Active Design. This is basically the same idea. If you're going to redevelop a neighborhood, build a brand new neighborhood, you can get certified as having designed it in a way that cooks health into the design. And so I advise both Fitwell and the National Wellbeing Institute. We advise the city. So our fingerprints are sort of all over the three major design guideline certification programs that are in the US for trying to design health into communities, development projects, and buildings. So this is how we translate our work. And so I've got screenshots of three of the, I think there's now 4 active design guideline books from New York City. I haven't got the 4th up there yet. So this is how we try and sort of translate our work and disseminate our work into policy. I have a ton of collaborators because I've been working on this for years and years and years. So this includes people from the Department of Health, epidemiology, GIS, urban sociology, and we've been luckily funded by NCI, CDC, and foundations, and the City of New York to do this work. That's all I have for you. Thank you for your kind attention. I will try my best to answer any questions you might have.
Fantastic. Any questions for Andrew?
Yeah.
Laura?
Hi, Andrew, it was really, really interesting. Thank you. I was just wondering in terms of the walkable destinations, whether you thought about sort of separating them out into sort of health promoting destinations and health detrimental destinations, you know, fast food outlets versus, I don't know, health food store.
We've had the hugest arguments about this. So yes, we've got a measure of total walkable destinations, like everything you might need. We've got healthy food destinations, unhealthy food destinations we couldn't figure out a label for that are just like intermediate, I guess we call them. We've got venues for physical activity. We've also scored each venue for the maximum energy expenditure you could expect to expend there. So like dance studios versus bowling alleys, right? So we've got places where you engage in physical activity, and then we've got them sort of like bucketed into intensity of physical activity. We've had huge arguments about how to fit every business you can imagine. All right, show of hands. A place where you can buy fish, come home and cook. Healthy or unhealthy?
Healthy.
Healthy.
Right, you would think. We had the worst arguments about this. So in wealthy neighborhoods, we have these gorgeous fish markets where you could buy fish, bring it home, steam it with a light sauce. In poorer neighborhoods, fish places function as a fast food joint. So what happens is you can say, I want that piece of fish and I want it fried. So if you just spend a bunch of time sitting in front of a fish store in Washington Heights or Harlem, you will see that they are selling tons and tons of fried shrimp, fried scallop, and fried fish. And so the health value, if you were to try and assign it to that kind of business, is highly dependent on the context of the neighborhood that business is in. So these are the kinds of arguments we've had. So fish stores ended up in the unclassifiable bucket. But yeah, we worked on it. We've got a bunch of papers on healthy food, unhealthy food, using our various sort of value-based labeling systems. One funny story is that we spent days and days and days trying to identify all of these venues for physical activity. So gyms, that's super easy, right? Karate studios, martial arts studios, yoga studios, Pilates studios, so on and so on and so on. So somebody argued that we should have dance studios in there. It's like, sure, you spend a lot of energy dancing. So we combed through 30 years of data, labeled all of these businesses as physical activity venues. We did our spot checking, our due diligence. What we found was that like strip clubs had gotten moved into our physical activity venues because it turns out that in the United States, most strip clubs label themselves in the official data as dance studios. So we then had to comb through and come up with text search strings to like move out all of these businesses with names you would imagine for a strip club to get them out of our physical activity venue bucket. So 46% Burger Kings do not use the code for fast food. They use the code for American food. So yes, we've spent a lot of time in it. Sorry.
Paul? So that's a question to you as an epidemiologist,
Oh, God.
researcher and academic. So really thinking big picture here. And you said you started off saying your initial idea of your advice was radical, and then fast forward where we are now, it's been much more normalised, largely underpinned by what is really quite strong evidence, I would say. So I feel we've got some really great answers here, and those last slides you presented show how you're translating. How much do we, as academic researchers, need to engage within the political science field to further translate that evidence, which I think, if we look at physical activity, walkability, the impact on health outcomes, do we know the answers? We need to do more in that area.
I feel like in my training as epidemiologist, I got no information or content on that topic. So we've been winging it. One of the great things about partnering with New York City is they have entire teams. So there was a project to get supermarkets into underserved neighborhoods. And they used a lot of our data as a scientific basis for that. But they had an office of people who went out to like community boards to talk about this, talked to the planning department to get code variances so you could build supermarkets. And so what I've learned is that if I make the right partnerships with like city agencies from the get-go, I'm almost like subcontracting that political science piece to my partners. And so I'm doing work now on urban forestry. And I made sure that somebody on my team is actually from the United States Department of Forestry. So I have that person with policy knowledge on the team from the very beginning. So that's how I'm handling it. I don't know how common that is in my field in the US. And I think there is a gap because I didn't get any training in it. My EPI program still has 0 training in it today. But yeah, I think it's a big gap.
I'm a believer, first of all, so I'm not answering from a cynical perspective, but evidence is though that if we change the walkability of the neighbourhood, that people will actually change their behaviour. I mean, I understand that in public health interventions it's a drip effect, but people choose where they live.
Yep.
People will leave the West End when there's no place to park their cars if they're a car lover. You know, there's a choice in where you live, and that is impacted by what people like, whether they like parks or whether they love their car instead. So, I mean, are there nice studies that present that evidence?
I would say the
show
evidence
that?
for like natural experiments in this field is pretty scant in the US. So not much evidence. We've done a number of projects where we thought there was going to be a change. And so we put together a grant proposal to like collect data before and after that change. And then the change doesn't happen because of politics and they never get around to demolishing or building the thing. And so that happens all the time. So there's there's tons of observational data like I traffic in. There's very little sort of natural experiment data available. One of the things about New York City is that where you can live and where you might want to live is really, really constrained by income, SES. Race, ethnicity also have a huge influence on where people live. And it turns out that the most walkable portions of our city are actually in some of the lowest income areas. And so that normal sort of like social determinants of health story of everything being confounded by income and education is actually flipped, where we do a lot of our work. So we take some sort of like hooker from that, I guess. But yeah, the natural experiment literature is a lot smaller. And yeah, my colleague Gina Lavasi has tried to do it, and like things don't get changed in the time frame we thought it would within the grant funding period that we have funds for. Yeah, it's mainly observational and a variety of like, if we adjust for this or do inverse probability weighting or propensity score matching, we still see the same effect. If we try and do this study in a place where the structure of confounding is completely different than in some other place, do we still see the same effect? So we do that like epi toolbox tricks, observational epi.
I mean, we've just come to 2 o'clock, but hopefully you're still here. So if any questions, chat to Andrew. But thank you so much, and thanks for visiting us. I'm really pleased to